Good morning everyone. I am Mrs. Amala Nambike. I am going to take a class Anemia in Pregnancy Unit 7. Today we are going to discuss about the anemia in pregnancy. What are the definition, incidents, causes, signs and symptoms, treatment methods. So everything we are going to discuss anemia in pregnancy. It is one of the common conditions occur widely. So it's a very important topic. Let's discuss anemia in pregnancy. Definition. According to WHO, anemia in pregnancy is when the hemoglobin concentration in the peripheral blood is 11 gram per 100 ml or less than that. However, because of prevailing socio-economic deprivations in the developing country, the level brought down to 10 gram per 100 ml. So WHO given there is a more than a 12 grams per 100 ml of hemoglobin concentration considered as normal, and 11 less than 11 gram per 100 ml is hemoglobin concentration is considered as a anemia in pregnancy according to WHO. But socio-economic deprivations, the developing countries, we are considered 10 grams per 100 ml of hemoglobin concentration, and less than that 10 and less than 10 grams per 100 ml of hemoglobin concentration is considered as a anemia in pregnancy. Clear? Incidence. Anemia in pregnancy ranges widely from the 40 to 80% in the tropic compared to 10 to 20% in the developed countries. That is because of socio-economic developing countries socio-economic status, like our India. So it's the most common diseases because of this socio-economic status. So 40 to 80% in our India incidence. So but whereas the developed countries it's a 10 to 20% occur. Then classification. The major classification is physiological anemia of pregnancy and pathological anemia in pregnancy. So physiological anemia in pregnancy, and the major classification is physiological anemia in pregnancy and pathological anemia in pregnancy. Let's discuss physiological anemia in pregnancy. Physiological anemia in pregnancy due to the physiological changes during pregnancy in the blood. All the system by system there is a physiological changes occur during pregnancy. Same way in the blood also physiological changes occur. You may study already. Physiological changes occur in the system by system. Here the physiological changes, that is a hemodilution and negative iron balances occur. They may lead to the physiological anemia in pregnancy. Hemodilution, there is a decreased hemoglobin concentration during pregnancy is due to the combined effect of hemodilution and negative iron balance. Hemodilution, there is increase in blood volume because of this in order to meet the increasing demand of the fetal requirements. Reproductive system, the maternal reproductive system is developed. This needs is increasing, so that hemodilution is occur, and also the negative iron balance. Negative iron balance means low serum level and increasing the iron binding capacity. Iron binding capacity of the RBC is increased, whereas the serum iron level concentration is decreased. So this negative balance is occur in the blood. So this may be the reason for the physiological anemia in pregnancy. So hemodilution and negative iron balance may lead to the physiological anemia in pregnancy. So 1000 milligrams is needed for the iron in order to meet the growing fetus. 300 milligram and 500 milligram for the erythropoiesis. Erythropoiesis process means the production of blood cells. There is RBC, WBC, platelets, plasma volumes. So everything is occurring in erythropoiesis. So there is a production of all those things is increasing. So the 500 milligram is needed for the hemoglobin, is need the iron requirements for the maternal erythropoiesis, and 300 mg for the fetal requirements, and remaining 200 mg for the there is a daily loss of maternal loss of iron. So totally 1000 mg is needed every day iron requirements. So that may lead to the physiological anemia. So this clear, the physiological anemia in pregnancy. And next, pathological anemia in pregnancy. The major classification is pathological anemia in pregnancy. Under that, the first one is a nutrition deficiency anemia. Nutrition deficiency anemia means in that iron deficiency anemia, folic acid deficiency anemia, vitamin B12 deficiency anemia, protein deficiency anemia. So, if you are remember about the erythropoiesis process of this production of the RBC, how the new RBCs, RBC lifespan of RBC is 90 days only in adult. So here 120 days for the adult. So here this RBC, the RBC is production is DNA in RBC is a blood cell. The production of the RNA, DNA, this folic acid and vitamin C and thiamine, the protein, uranic acid, the blood, vitamin B12, the protein particles, everything is needed for the erythropoiesis, the production of RBC, DNA and RNA of the RBC. So and also iron requirements. So this may leads to the anemia during pregnancy. Any deficiency of the iron or folic acid, vitamin B12 and protein may lead to the anemia in pregnancy. And next is an hemorrhagic condition. So and under the hemorrhagic condition, acute the following bleeding in early months or APH. So during the pregnancy, early months, if the history of any bleeding disorder, so there is a APH, antepartum hemorrhage, the history of antepartum hemorrhage, so that may lead to the anemia in pregnancy. Second one is a chronic, that hookworm infestation and bleeding piles, any chronic diseases, the history of chronic disease of the mother, so the hookworm infestation and bleeding piles, like that. If any history is there, means the daily loss of blood is there, so then automatically the mother may get the chance to pathological anemia in pregnancy. Next, so hemolytic anemia. This hemolytic anemia is under this hereditary, this familial. So this thalassemia, sickle cell anemia and other hemoglobin diseases. So that's a genes already the mother may having the career of the thalassemia, sickle cell anemia. So this is the erythropoiesis itself. So there's a blood structures and the proteins, the amino acids. So itself there's the production RBC, abnormal RBCs and the erythropoiesis systems are already totally having the hereditary disease of all those things, means the mother may getting the pathological anemia in pregnancy. And next is an acute. Acute means the malaria, severe infections, and malaria. So the WBC level is everything is affected. WBC, RBC, plasma volume and all the total blood volumes. So everything is affected. So simultaneously the mother may get the pathological anemia in pregnancy. And next is bone marrow insufficiency, hypoplasia. So hypoplasia due to the radiation, drugs. Example, aspirin and indometacin. So the bone marrow is the place, the erythropoiesis, that means production of RBC, WBC, and everything is occur in the bone marrow only. Here like a cancerous, that's a abnormal development of the abnormal cells of RBC. So in the bone marrow itself had getting some problems, means that may leads to the due to the radiation exposures and aspirin, the drugs, history of drug intake, so may leads to the pathological anemia in pregnancy. Next, that's all about the pathological anemia in pregnancy. So pathological anemia in pregnancy is one is a nutrition deficiency anemia. Second one is an hemorrhagic anemia. Third one is an hemolytic anemia. It may be a hereditary acquired or bone marrow insufficiencies or hemoglobinopathies. Everything is may leads to the pathological anemia. And next is an causes of anemia during pregnancy. Causes of anemia, it's vary. So first is a pre-pregnant health status. The women before going to get the pregnancy, if their health condition is already having the some history of ill health. Ill health may leads to the anemia in pregnancy. Pre-pregnant health status, that is before this 21 years of age, that is end of the teenagers, before completely development of the reproductive system of the female. If the female get the pregnancy means, so simultaneously it may affect the all the systems, so including anemia also the one of the reason due to the pre-pregnant health status. And yearly then frequent pregnancy, prolonged lactations, so there's multiple pregnancy, there's a previous history of the health conditions may lead to the anemia in pregnancy. And next is an increasing demand of iron. Increasing demand of iron, already I told, there is an multiple pregnancy, that is the frequent pregnancy, this yearly, there is the history of there is a prolonged lactation and become pregnant, next pregnant. So these are all the reason for the increasing demand of the iron. So this is one of the reason, and for the anemia in pregnancy. And next is a diminished intake of iron. So due to the hyperemesis gravidarum, vomiting, and faulty diet habit. So some of the mothers may inadequate intake of the balanced diet, and they may having the diminished iron intake, hyperemesis gravidarum, loss of iron. So that may be the leads to this anemia in pregnancy. And next is a disturbed metabolism. Disturbed metabolisms may be this erythropoiesis itself, metabolism. There's an this iron binding capacity, there's iron absorption, insoluble iron may be occur in the intestines, inadequate absorption. So metabolism, the breaking down and the catabolism, so the everything is affected. The metabolism itself, the intestines, there's the increasing carbohydrate diet, the increasing intake of carbohydrate may leads to the this insoluble iron in the intestine. So the absorption, the absorption may be affected in the iron absorption is affected in the intestine. So they may leads to the disturbed metabolism, so leads to the anemia in pregnancy. And next is an excess demand. Excess demands means already I told the multiple pregnancy, there is an frequent pregnancy, and there is unplanned pregnancy. So the increasing demands of the iron, so may leads to the anemia in pregnancy. And polymorphism, the polymorphism means the in the bone marrow, erythropoiesis is occurred, RBC productions, everything is occurred here only. So here itself, the erythropoiesis itself somewhat is affected because of vitamin B12 deficiency, iron, the vitamin B12, vitamin C, folic acid, protein, amino acids. So these are the thing is inadequate demands. There is inadequate intake, and also it may this bone marrow itself having the problem. So the polymorphism may occur. So leads to the anemia in pregnancy. Next, risk factor for anemia. Risk factor for anemia is a faulty dietary habit. Faulty diet habit, already I told. So that is the maternal intake of balanced diet, iron-rich diet. Faulty diet have carbohydrate increase the diet, and starvations, and these are all the reasons may be the risk factor, the mother risk factor for the anemia in pregnancy. And faulty absorption, as I told, there's this metabolism, the absorption is having the in the intestine, any absorption is affected, insoluble iron, and this may leads to the faulty absorption of the iron and the blood in the intestines. So that may leads to the anemia in pregnancy. And next is an iron loss. Iron loss is an already I told you, every day iron loss. The intestine hurry up. Intestine hurry up. Sometimes the intestine having the hurry up frequently. They may getting the this like diabetic. So that may leads to the anemia in pregnancy. And iron loss. Iron loss it's due to the vomiting and sweating, and also the APH, any history of bleeding piles, so and also any infectious disease, hookworm infestations, all these things is a risk factor. These are the risk factor for the anemia. Next is an iron deficiency anemia. Iron deficiency is anemia is a common condition, so you may know. So already is a common condition. So we heard this. So the iron deficiency anemia, we have to discuss about a important topic here. This an because of it's a very common conditions occur, medical conditions occur. Here is first some symptoms. So how the mother may feel as an feeling weakness, exhaustion, and easy fatigability. So say they may feel as an activity intolerance. As a nurse, we can find out the activity intolerance. They may having the dyspnea. They may having the giddiness and anorexia. They may having the complaints of symptoms of indigestion. And if you are auscultation, through the auscultation, you can find out the palpitations, and they may feel as an breathlessness and exertion, and sometimes the preeclampsia condition like any edema in leg, that is an hypoproteinemia or associated with the preeclampsia hypoproteinemia. So I already don't know, there's an intracellular dehydration, extracellular overhydration. That means the fluid is shift from the intracellular to the extracellular. So that may lead to the edema. There is condition of hypoproteinemia, the amino acid and the deficiency, protein intake. So protein here is a protein metabolism itself getting affected. So that may lead to the edema in leg. So these are the some of the signs and symptoms. It's a common signs and symptoms. We well known about the anemia symptoms. We our life also sometimes we may experience all these things. If we are not taking diet properly, means we may getting this anorexia, palpitations, and something we may breathlessness. So we can find out easily. As a nurse, we can find out anemia very easily the symptoms. Next is screening and assessment. How we can screen this assessment of anemia in pregnancy. So before going to the discuss about this degree of anemia, we are clinical classification is three classification. Three degrees we are having. We are dividing to the three categories, three degree of anemia in pregnancy. So mild anemia means the hemoglobin level 8 to 10 gram per 100 ml is considered as a mild anemia. 8, 9, 10 milligram per 100 ml is considered as a mild anemia. And moderate anemia is 6.5 to less than 8 gram. 8 gram or less than 8, 6.57 milligram per 100 ml is considered as a moderate anemia in pregnancy. And next is a severe, less than 6.5 grams per 100 ml is considered as an severe anemia in pregnancy. So 3 degrees of anemia, 8 to 10 grams per 100 ml is considered as a mild anemia. Moderate anemia is 6.5 and less. Between the 8 and moderate anemia, and severe is less than 6.5 milligrams per 100 ml. So this is called as degrees of anemia. Okay, so then examination. In examination we are using the inspection, palpation, percussion, auscultation. So we are the nurse, we are the first messenger, so we have to carefully assess head to toe assessment itself, physiological assessment itself. We can physical assessment, just a simple assessment, through that we can find out. First one is a pallor, you know very well, that's we're checking of eyes, and inspection by seeing the this tongue color. So they may look as a pallor. and edema of the legs, and soft in the auscultations we can hear the soft systolic murmur in the heart sound, and also crepitations may be heard as a base of the lungs because of the this value, lung value. So somewhat is disturbed, so that we may get the auscultations, all those things, and palpitation. This if you are find out the edema, the leg edema, legs we can find out the edema. So these are the on the examination we can find out easily. Examination, pallor, edema of the legs, soft systolic murmur in the during the auscultations. So auscultations may be. So these are the auscultation methods we can find out all those things. Next is an investigations. So how we can investigate the anemia in pregnancy? First is peripheral blood smear. So we have to take a peripheral blood smear, and we can go for a blood study, chemical studies, all the values. So red blood cells value and white blood cells value, platelet value, cells, and hematological. So there is a mean corpuscular value, mean corpuscular hemoglobin concentration, and packed cell value, CBC, complete blood count, and hemoglobin level. These are the things we can investigate and find out how the anemia we can categorize as a mild, moderate, severe, like that we can find out, and according to that we can treat. And next is an examination of the stool. So for the bleeding piles, so and any infections, worm infestation, we can find out through the examination of the stool. And urine, and there is any urinary infections or urinary disorders, any kidney disorders, we can find out through the urine examinations. That is also one of the reason for the daily loss of iron, that may bleeding blood that may leads to the anemia. So we can find out through that. And bone marrow studies, and in the extreme cases thalassemia, sickle cell anemia, any hereditary diseases, so that we can find out through the bone marrow studies. These are the investigation method of the anemia in pregnancy. Next, treatment. How we can treat the anemia in pregnancy? So prophylactic and curative. So the prophylactic methods we are one by one we can discuss, and avoidance of frequent childbirth. So we have to discuss about the ask the mother at least 3 years between the previous pregnancy and present pregnancy. So that is good for the everyone because of the at least 2 years. So because of replacement of the all the WBCs and everything, the avoidance we have to advise the mother to avoidance of the frequent childbirth. First one. And next is an supplementary iron therapy. So here even we are nowadays and all through the primary health center, we are school health nursing itself, we are going for a school health itself, adolescents, students, teenage students, we are meeting, and we are giving iron tablet every day, supplements of the iron supplements to the there's a 1 milligram of folic acid, including the 20 milligram of iron, and tablets is available. It's totally 60 milligram. We are giving the iron supplements therapy in the primary health center itself. We are giving a iron supplement therapy. And dietary prescription, so that we can ask the mother to take a iron rich diet. Dietary advice, we are giving a health education about the balanced diet, iron rich diet, and through that the mother may get the awareness about the anemia and how to prevent, and we can prevent all these things, the anemia in pregnancy. And next is an early detection as by the every routine checkups in the early detection. So in the first trimester or pre-pregnancy itself, planned, the mother who are all eligible to get or planned to pregnant, so that time itself we are administering folic acid, iron tablets, and we are assessing, and during the first trimester itself we are assessing the hemoglobin level, and we are doing those things, and the early detection may prevent a series of complications in anemia in pregnancy. So early as much as possible, we have through that inspection itself we can find out, and further in blood investigations we can treat the mother, so that it will be helpful for the second trimester and third trimester. We may avoid some serious complications during the pregnancy. So this is the prophylactic methods. Next is an curative methods. Curative methods, we are giving a oral therapy and parenteral therapy. So here the oral therapy, daily administration of 200 milligram of ferrous sulfate contains 60 milligram of elements of iron along with 1 milligram of folic acid. The pre-pregnancy itself, 1 milligram of this folic acid tablets we are administering, and 200 milligram of ferrous sulfate containing the 60 milligram of element of iron. So we are advising and we are giving to the in the primary health center itself. Government is giving freely. So these are, and next is an intramuscular therapy injections, iron external injections, iron sorbate. So everything is available. Jectoffer injections. So we are giving administering 1 ml ampule, 2 ml ampule is available. So we are administering this injection. And next is an intravenous route in the total dose infusion, that is a TDI, total dose infusion. Here this is 2 ml or 5 ml ampule. 1 ml ampule is containing 100 ml of 50 ml of elemental iron. 1 ml is having the 50 milligram of iron, and 2 ml is having the 100 milligram, and up to 5 ml of iron sucrose injections and infusion with the saline, and we are infusing intravenously. So intravenously iron sucrose injection. So we are routinely that is an within a day, that is an frequently and periodically we are replacing this intravenous infusions in the primary health center itself. This is the one of the method of treatment for the anemia. And next, in case of thalassemia, sickle cell anemia and severe cases, APH, PPH and all, so we have to do the blood transfusion. To the anemia is very important. Here there's a condition, medical condition, very worst conditions, so we may go for a blood transfusion. Is one of the treatment method of anemia. And next is an exchange transfusion. We know very well the cardiac failure, severe cases of anemia requires the emergency surgery. So during that exchange transfusion, so the 1300 milligram of packed cells we are infusing through the brachial veins, and this same time the femoral veins we are withdrawing the this old blood, the defected blood outside. So that exchange transfusion, exchanging the packed blood cells. So we are infusing the packed cells inside, and we are taking out of the the defective blood. So that thalassemia, sickle cell anemia and all. So we can do this like this cardiac failure and all. We can prevent this thing, this maternal death and all. So during the time exchange transfusion we can go for that. That's all about the treatment methods. So again, treatment methods is an prophylactic methods. So we are doing some prophylactic methods, and curative is an oral therapy, parenteral therapy, IV infusions, tablets, and injections, and blood, in case of the severe cases, blood transfusion and exchange transfusions. So these are the treatment methods for the anemia in pregnancy. And finally, nursing management, nursing care, nursing diagnosis. We have to focus on the first one is an breathlessness or dyspnea. We have to assessment. We have a pallor and head-to-toe assessment, inspection, palpation, percussion, auscultation are the methods. Through that we can find out the this anemia very easily. So obviously in the inspection itself, the pallor, so we are the first messenger. We have to find out the this anemia in pregnancy. So early identification. We are if the mother is having the any breathlessness, hypoxia, palpitations, so we are giving importance to the this impaired gas exchanges and this severe conditions. So, and next is an activity intolerance, fatigue. So the mother may get the giddiness and fatigue, activity intolerance. So they can do the normal work, normal things. So they may getting the weak and exhausted. So they may feel all those things. So the activity intolerance, fatigue we have to give importance. And then nutrition, so nutritional defect, so deficiency in nutrition, so the inadequate intake of iron, so we have to concentration on the nutrition, very important. And the health education, the mother has to get the balanced diet and dietary advices. And through that we can find out the edema, preeclampsia, so identification of APH, so all these things, the fluid volume, APH and all fluid volume deficit, we have to give importance to the fluid volume deficit, so we have to replace it, so blood transfusion or the exchange transfusion, anything, so we intravenous infusions of the iron sucrose, so like that we have to give the thing. So these are all the nursing management. And also the we have to fear and anxiety, the mother may be getting the fear and anxiety of the both the mother conditions and then baby conditions, so they may be getting the fear and anxiety. So these are all the nursing part we have to concentrate. And it's a very important condition, it's a common condition also, common condition, anemia in pregnancy. So 40 to 80% of the pregnant women is getting the anemia, chance to getting the anemia, both physiological anemia, pathological anemia. So whatever it may be, we are the nurses, we have to what's the our part is for inspection, through the inspection the early identification of the anemia. So even more the mother, we are the community nurse has to concentrate on the home visit itself, those who are all the reproductive age and plan for pregnancy, so we can administer the folic acid and iron tablets, so like that. And we can give the health education to the balanced diet, like that we can prevent the anemia. It's a preventable, it's a medical concern, it's a preventable. So we are the important role, nurses, we are the important role, plays an important role to find out and screening and assessment of the anemia in pregnancy. We have to prevent the series of complications. So in the beginning itself, identifications and treatment and careful assessment, through that we can prevent the anemia, complicated conditions. So good luck. We are the nurse, we have a satisfaction of early identification, preventing of the serious complication, means it's so happy of we are giving a healthy future generation to the world, future healthy mother and healthy baby to the unhealthy future world, to the future generation to the world, isn't it? So is our part. Let's still we have discussed about definition for the anemia, and what is the definition WHO given, what is the socioeconomic status. We are having the 10 grams per 100 ml is considered as an anemia, mild, moderate, severe classifications, and what are the causes, inadequate intake, faulty diet, and also many of the risk factors, and many of the causes anemia, and classifications of anemia, and how to assess the screening and assessment of the anemia, detection of early stage, and how to treat the anemia. So these are the discussed. I hope you got my point. And as a nurse, we have the important role. We have to study well, and we have to find out and prevent the complications. Wish you all the best. Thank you.